The following lecture will cover inflammatory bowel disease for a group of Concepts 2 students during the concept of elimination GI. Inflammatory bowel disease. We mostly see this disease, of course it's an autoimmune disorder, so as we learned from our autoimmune lectures, women are at a greater risk of having autoimmune diseases. Age. Both of these autoimmune diseases actually have an early onset of the disease. It can be seen as early as 8 and can also be seen up into the early 20s. So during the time of growth and development of teenage years is when the disease usually strikes. Genetics. We learned from that this disease is an autoimmune disorder, so it is genetically linked with all other autoimmune disorders. Causes. The causes really are things that would cause an exacerbation. All autoimmune disorders have remissions and exacerbations. So things that can cause exacerbations are stress, anxiety, and dietary changes. And then, of course, we have remissions and exacerbations. When we go through the lecture, you'll see it's broken into two different areas, short-term goals and long-term goals. So short-term goals would be those goals where the patient has been hospitalized, and long-term goals are for remission. So short-term goals are for exacerbation, long-term goals are for remission. Inflammatory bowel disease is an umbrella that has two different disease processes within it. The first is ulcerative colitis. Ulcerative colitis affects the mucosal layers of the bowel, starts in the lower sigmoid colon, and goes up the left side of the bowel. Often called left-sided colitis, patients that have ulcerative colitis will have large amounts of bloody diarrhea, and the blood will be bright red because it's in the lower portion of the bowel. Crohn's disease. Crohn's disease can be seen in any area of the GI system from the mouth to the anus. Most normally, Crohn's disease is seen in the small bowel or the ileum, where a large portion of absorption takes place. Another differentiation between Crohn's and ulcerative colitis is with Crohn's disease, the inflammation eats through all layers of the bowel, not just the mucosal layers of the bowel, causing the bowel to become friable and ripped. On the right-hand side of the screen, you'll see something that it's actually a piece of bowel, and you'll see the area on the left side of that picture is necrotic and brown, and it's an area where the disease has actually gone through all layers of the bowel. So just to review, ulcerative colitis are the first layers of the bowel, cause large amounts of bloody diarrhea. It's seen in the left-sided colitis. It's also associated with left-sided pain, lower left abdominal quadrant pain. Patients with Crohn's disease, the most common area of the disease process is in the ileum, which would be right lower quadrant up to the midline of the quadrant pain. And this disease process goes through all layers of the bowel, causing peritonitis, fistulas. Clinical manifestations. So ulcerative colitis usually have left lower quadrant pain that's relieved with defecation, abdominal pain and cramping over the diseased area of bowels. They can have 10 to 20 bloody stools per day. Remember, that blood is bright red blood. They have nutritional deficits. Usually our nutritional deficits here are because when a patient is in the middle of an exacerbation and having large amounts of diarrhea, they will be self-limiting on what they eat. You can also imagine that if they are having large amounts of diarrhea, the electrolytes are not absorbed properly. Additionally, these patients can have arthritis, usually rheumatoid arthritis of the hips, as well as iritis, which is an inflammation of the iris in the eye. Crohn's disease. They have pain, tenderness, and guarded movement over the area of diseased bowel. Sometimes they can have a palpable mass in the right lower quadrant, and that's where the ileum connects to the large bowel. And sometimes they can get something called pouchitis or pocketitis, where that area actually becomes extremely inflamed and enlarged, and they can have an abscess there as well. 5 to 6 loose stools a day. Bloody only if the disease is seen in the ileum. So usually it's the dark, tarry old blood that we see. They have steatorrhea, which means that they have large amounts of fecal fat, or they have fat in their stool. If the disease is in the ileum, they are not able to absorb the fat, which as well as with the nutritional deficits, they're not able to absorb the fat. And the other clinical manifestation that's important with Crohn's disease is that they may present with a fever. The fever can be related to the onset of the disease process eating through all layers of the bowel and causing peritonitis and a fistula. Diagnostic testing. So for ulcerative colitis, when we look at their labs, they're having large amounts of diarrhea that your patient's dehydrated. Think about what's going to happen to your sodium. Your sodium is going to be increased because of concentration issues. If they have large amounts of diarrhea and they lose lots of potassium, they're going to be hypokalemic. Lab, hemoglobin hematocrit in this patient can sometimes be tricky to understand. If they're dehydrated, their hemoglobin hematocrit is going to increase. However, these patients often have large amounts of blood in their stool, so if they're losing blood volume, their hemoglobin hematocrit will be decreased. Diagnostic testing to understand the severity of the disease and where the disease is located. You can have a barium enema, which is often called a lower GI series, where they place barium in the rectum through an enema, and then where the barium lines the intestine will show up on the screen. The biggest nursing indications for patients having a barium enema is that they stay well hydrated before and after the procedure. Before the procedure, there's usually some type of Before the procedure, there's usually some type of bowel prep done to clean the bowel, and then after the procedure, they may have another enema to help them rid their bowel of the barium. A sigmoidoscopy, which is a colonoscopy, just going into the sigmoid part of the colon, or the first section of the large intestine. Crohn's disease. These patients' labs, these are the patients that have the nutritional deficits. So their albumin and their protein are going to be low. Their calcium may be low. Anything that they have to absorb in their intestine will be low. Their labs are affected by the amount of diarrhea that they have. These patients can also have a barium enema, but they may have a barium swallow, which is called an upper GI series, because remember, this disease happens further up in the intestinal tract, and they may not be able to actually view it through a scope. They can have a sigmoidoscopy or a colonoscopy as well. So here we have the nursing process, the plan section. We're looking at short-term goals. I'm going to go through these short-term goals in relation to the nursing interventions relevant to each goal. So abdominal pain and cramping. Lots of times when we think about abdominal pain, we think, give them narcotics, medicate them, give them pain medication. But that's not always the best answer. You have to think about what's causing the pain. And in these patients, what's causing the pain is cramping. So we can give them probanthine or bentyl. Both of those drugs have a drying effect, so you definitely want to watch out for constipation with these patients that are taking both probanthine and bentyl. But what that does is it helps relieve cramping. The other thing that's causing these patients pain is actual irritation of the intestinal lining. So nutrition is part of the pain and cramping. So we would make them MPO, and then we slowly progress them. So they may have TPN. Please remember all of your past knowledge about TPN and why TPN is most effective for these patients. Why we give TPN to allow for bowel rest. The next thing that they could have would be an elemental formula, such as Ensure. We like elemental formulas because they're already started to be broken down. When we think about things after an exacerbation that our Crohn's and ulcerative colitis patients should have, they're things that are soft, that don't take the intestines a large amount of work to break down, because that work will cause increased inflammation. And the non-pharmacological methods, usually this is considered stress reduction and a quiet environment, music, relaxation. and also position of conflict, whatever is most appropriate for your patient. Prevention of fluid volume deficit. First, we're going to replace fluid volume. We'd give IV fluids. This is where you need to understand the difference in different types of IV orders. So if I have a patient that's hypotensive and tachycardic, I'm going to give them a large amount of IV fluid over a small period of time. So I may give them 500 cc's over an hour, 1,000 cc's over an hour. If I have a patient who is actively vomiting but maybe has a fairly stable blood pressure, I would give them a maintenance dose. So 100 cc's an hour, or maybe 150 cc's an hour for replenishment. Pharmacology. So with this little triad of drugs here, there's actually an order which they take them. The first thing we're going to give a patient, the first thing even a patient will be told to take it home if they start to experience a large amount of diarrhea so that they don't have a fluid volume deficit, is Imodium. Imodium is an over-the-counter drug to stop constipation. The next thing that we would have them take would be Lamodal. And the thing about Lamodal is it has an atropine in it, and atropine has a drying effect to it, so cholinergic drug. So that's actually what helps stop the diarrhea. It helps dry the patient up, so it has a dehydrating effect, and that actually helps with the diarrhea. And then finally, the last thing we give is paregoric, or it's camphorated opium tincture. So here, it is opium. So opium is the base for our narcotics. Think of opium as the base for heroin. And all the side effects that go along with opiums, we still have to watch your patient for them here. So decreased CNS effects. It causes constipation, which is part of the reason we're using it here. So we're trying to stop the diarrhea, dry the patient up to stop the constipation. They take Lamodal first. They take Imodium first, they take Lamodal, and then they would take paregoric. So reduction of intestinal inflammation. We would give aminosalicylates such as Ascol and Pentasa. Please note that these drugs have salicylate in them, so if they're allergic to aspirin, they may not take these drugs. It can be taken orally for patients that have Crohn's disease. It can also be taken as a suppository for patients who have ulcerative colitis. Additionally, patients that are having exacerbations may take prednisone, which would be the PO, or prednisolone, delta-cortef, which would be the IV for Crohn's disease patients. You can also take topical steroids, such as retention enemas and rectal foams if your patient has colitis. Please remember all the side effects that go along with prednisone, such as hyperglycemia, visual changes, weight gain, blood pressure changes, how we never pull a patient off completely to reduce psychosis, etc. Absence of skin breakdown. These patients have a lot of diarrhea, so I'm not going to go through this. These are fundamental ways to prevent skin breakdown. The other reason these patients are at risk for skin breakdown is that if they are dehydrated and they have nutritional deficit, that also puts them at a higher risk. So they have some risk factors and they have diarrhea. You can see here skincare, mild soap and water, sitz baths, petroleum jelly, mineral oil, aloe creams, etc. I will say that under the mild soap and water, you can't, every time they have a bowel movement, they should not be using soap every time because it will have a drying effect on the skin. And then fatigue and anxiety. We want to promote rest. We want to cluster care as much as possible. Allow for times of rest, especially during the evening and nighttime hours. So if your patients are fairly stable and they're not having a large amount of diarrhea, their blood pressure's been okay, it would be appropriate to not wake them up in the middle of the night for vital signs, things like that. And reduction of anxiety. So to remember here what type of patient population we're talking about. It happens more for females, and the onset of age. So we're looking at our adolescents and our prepubescents and our young adults. And you think about how that age range copes with things. And if any of you have ever had a teenage girl or been a teenage girl or dated a teenage girl, you know they like to talk a lot. So promoting, reducing that anxiety may be allowing them to talk, maybe just listening to what they have to say and letting them go through their range of emotions to help reduce their anxiety. So now we have long-term goals. These are the things that we want to promote during a remission. So normal bowel elimination patterns. That's a big goal for our patients with ulcerative colitis and Crohn's. And all that is really up to them to determine the relationship between food and bowel movements. Understanding where they have bathroom access, color and consistency of stool will help determine what type of pharmacology they need to take. So the color and consistency, if we go from a formed stool that's brown to a soft stool that has streaks of old blood in it, that would be a reason for maybe them to call the doctor. Or if they always have those streaks of dried blood in their stool, that's not a reason for them to call the doctor. So all of that color, consistency, relationship, bathroom access, those ideas are very patient-centered. So patient-centered care, understanding what's most appropriate for the patient. Obviously, 10 to 20 liquid bloody stools a day, any type of major increase in their diarrhea, and bright red blood would be a reason for them to seek care. Pharmacology. With this, remember that little triad of meds. They're going to get Imodium, Lomotil, and then paregoric. Oftentimes, their physician, part of their plan of care is, at the first sign of diarrhea, they need to take Imodium to prevent any fluid volume deficit. So reduction in intestinal inflammation. Remember, this is an autoimmune disorder. So all of those drugs that a lupus patient would get, these patients also get. Common ones are Sandamune, methotrexate, mercaptan, and then Humira and Remicade. Humira and Remicade are actually the most common drugs given for Crohn's and colitis. Humira is given sub-Q, Remicade is given IV. They're given in an outpatient basis. Sometimes patients will take them themselves. The biologic therapies do not come in PO forms. They come in sub-Q or IV forms. Sometimes they'll let patients give themselves their own Humira. It depends on the age of the patient and just any type of teaching barriers that there might be with the patient. Please remember all the side effects for methotrexate, such as birth defects, alopecia, and then the major side effects with Remicade and Humira are that they suppress the immune system, so they're at a greater risk for myelosuppression and they're at a greater risk for anemias. Additionally, with Remicade can cause heart failure. So it's very important that before, during, and after treatments, blood pressures are monitored to understand if the patient is going into heart failure. So hypertension would be a sign that our patient is having a cardiovascular reaction to the Remicade that's considered a side effect. On the other hand, Remicade, if someone is having an anaphylactic reaction to Remicade, if they're having a systemic reaction to Remicade, they will look like they're going through anaphylactic shock. And one of the first things you see with that is hypotension. So if your patient is hypotensive, we would need to stop the infusion and run saline and call a physician. Hypotension is a reason to hold Remicade. Hypertension is a sign that they're having an adverse reaction or a side effect of the drug. So maintenance of optimal nutrition and body weight. Obviously, they could still be on the TPN. They have long periods of bowel rest. They would next start out with elemental formulas, which would be like the Ensure, and then dietary modifications. So the first thing I want to impart is that, remember, this is an autoimmune disorder. So there's active inflammatory process going on. Think back to our immunity lecture and all of those dietary regulations to help boost their immune system. These patients, omega-3 fatty acids are very good for these patients, vitamin C's, folic acids, those types of additions to their diet are helpful. The other dietary modifications are these patients need to have a low fat, low fiber, you'll also hear it called roughage, high calorie diet, high protein. High protein for healing, high calorie for energy, low fat, fat irritates the intestinal wall, and low roughage or low fiber. The fiber will irritate the intestinal wall as well. Additionally, patients may take multivitamins. vitamin B12, vitamin C, vitamin D, and iron supplements, because they have a problem with absorption. So we want to give them as best possible chance to absorb something. We're going to overpower them with supplements as well as a good diet in hopes that their body will absorb the minimum of what they need. Coping. Remember, this is a chronic disease process. We want to think about stress reduction, support groups, the Inflammatory Bowel Disease, it's called the Crohn's and Colitis Foundation of America. They have lots of information on their website. And throughout Blackboard, I've used a lot of their information, pulling off a lot of their, especially their pharmacology sheets, to help with this type of disease process. So they have a lot of information there. And then also taking an active role in their health care, and patient-centered care will allow them to feel as if they have more control over the situation. Some potential complications that you can have from ulcerative colitis is a large GI bleed, or a lower GI bleed, so they can hemorrhage. Malabsorption, so remember, this is malabsorption of water, not of nutrients. So malabsorption of water, anemia, and the anemia comes from two different reasons. One is from self-imposed dietary restrictions, and two is from the potential of repeated hemorrhages. Risk of bowel perforation. The reason that these patients are more at risk of bowel perforation is because they have multiple colonoscopies. So the more colonoscopies they have through an area of inflamed bowel, it makes that bowel more able to break or more able to be perforated from a colonoscopy. And then increased risk for colorectal cancer. You'll notice that that's on both ulcerative colitis and Crohn's disease, because what happens is we have this inflammatory process that our body's going through. It will lay new tissue, and sometimes that tissue mutates, and those cells mutate incorrectly, or mutate does mean incorrectly, but the cells will mutate, and they're able to grow tumors from in those areas where they have ulcerative colitis. So they are at a higher risk, a lifelong risk of having colon cancer. Crohn's disease. So in the first couple slides, I talked about how you looked at that picture of the bowel, and you saw that little brownish area on the left-hand side. That is an area that is necrotic bowel. Sorry, that is an area that is necrotic bowel, and an area of necrotic bowel can actually allow the bowel to open, which causes a fistula. So the bowel opening is the fistula, and then the abscess is the infection that grows around it. So the most common place for patients with Crohn's disease to have a fistula is something called a vesicovaginal fistula, where their stool actually comes through the vaginal canal. So it is fixable. They actually fix it through almost like a hernia type operation, where they put some mesh in the bowel so that the stool stays in the bowel and doesn't go through into the vaginal vault. But how we figure out that a patient has a fistula, a vesicovaginal fistula, is often a urinalysis, because there'll be bacteria and there'll be E. coli in the stool. Additionally, patients that have Crohn's disease can have an obstruction. If we're always if you think about the diameter of the intestine, and we're always laying new cells inside the intestine to heal ourselves, there's a lot of scar tissue building up on the inside of their intestines. And the intestines then the diameter just gets smaller and smaller and smaller, and they end up causing some type of obstruction, because that's actually scar tissue has kind of blocked the area and stool cannot get past. Malabsorption. This malabsorption is because the inflammation is in the ileum, and they're unable to absorb any nutrients, which will also lead to anemias, because they're unable to absorb iron. And then the increased risk of colorectal cancer, just as in ulcerative colitis. So then surgical management. These patients can end up with ostomies. Very commonly do they end up with ostomies. So first let's talk about our ulcerative colitis patients. They can have a total proctocolectomy with a permanent ileostomy. So these patients have had all of their colon removed and they have a permanent ileostomy, meaning that their intestines end at the ileum. So none of the water has been reabsorbed and their stool will be complete liquid. So think about hydration status and skin-wise for these patients. They can have a total colectomy, which means they can have all of their bowel taken out, and they can have a continent ileostomy. The continent ileostomy, it's more like a pouch underneath their skin where they express the stool out, and they can see that it's getting larger, so they would need to self-express the stool out. Or they can have an ilioanal anastomosis, which means that we have now connect their ileum to their anus. Anastomosis just means put back together. So they still don't have a large bowel, but now instead of defecating through a pouch or an ostomy, the stool comes out of their rectum. Crohn's disease. They can have a bowel resection with or without anastomosis. So they'll have part of the diseased bowel taken out. Sometimes they put it back together, sometimes they don't. Patients that have Crohn's disease can also often have temporary ostomies. So they'll have an ostomy for a couple months or a couple years. It allows for the bowel below to heal, and then they re-anastomose after the bowel has healed. And then a strictureplasty. So a strictureplasty is kind of like a roto-rooter for the bowel. It scrapes off all the scar tissue on the inside of the bowel and allows the diameter of the bowel to become larger. Thank you.